Sorry. Okay, welcome to the Ethics for Lunch series. We're a little slim today because our residents are off, as it's just the turning of the residents this week. But thank you all for making time and coming. I'm Dr. Karen Smith. I'm Director of Ethics Integration here at the Henry Ford Health System, and I love Ethics for Lunch. I always learn so much, and I always say I learn so much because I do for my colleagues. Recently, we have had some questions about pharmacy issues and who gets the drugs and who decides and how those decisions are made. So we thought we'd do an Ethics for Lunch on this topic. And as always, it's just the tip of the iceberg. Once I started looking into this, it was just like this massive snowball of issues. And I thought, how do we narrow this down? So we didn't, but I hope you'll find a lot of things to think about after this session, and maybe have some ongoing discussions with our pharmacy friends. The American Pharmacists Association has a wonderful code of ethics, so that's where I always start with any group when I'm starting. What do they say their ethical values are, and what do they hold themselves up to? Pharmacy, like any other type of healthcare, is based upon moral obligations and virtues. This is their code. I highlighted some of the things that I find especially ethical about it, right? So the pharmacist is actually held in a middle position, needing to respect both the covenantal relationship between themselves and their patient, right? That's listed in number 1. To promote the good of every patient in a compassionate and confidential manner, so similar to other care relationships in healthcare. They also have to respect the autonomy and dignity of each patient to make decisions that they feel are best for themselves. Acting with honesty and integrity, of course. Maintaining professional competence. But then respecting the values and abilities of colleagues and other health professionals, right? Because they're the intermediary between physicians who write prescriptions and the patients who get them. And they're called to serve not only the individual, but also their community and societal needs. That's a very broad ask, right? And it'd be interesting to see. I think we could do a whole session on how do pharmacists best address this obligation that they have. And the last one, I think, is what we're seeing all the time. And I've talked to you before, and I said I think really the most difficult ethical issue facing healthcare is the issue of justice. When we think about justice and the code of ethics, which requires them to seek justice in the distribution of health resources, which of course would be medications, and how expensive things are, and how much they're controlled by other entities. Insurance isn't mentioned at all in this code of ethics, yet we all know that insurance drives a lot of healthcare, and certainly medications is one area where they show huge influence. Again, another area that could be a whole ethics talk, I think, right? So I want you to keep this code of ethics in mind as we talk about some of the other issues today. Again, I think this is a wonderful code of ethics, but boy, that's a really high bar to have to meet all of that all of the time. I think they do an amazing job of it. There was a recent study, it was done last year in 2018, because I thought, wow, I wonder what moral dilemmas pharmacists face. So I did a search, and this one came up. It ended up being really a pretty interesting study, Moral Dilemmas of Community Pharmacists, a narrative study. So they sent this study out to ask pharmacists open-ended questions. What sort of issues do you face? And of those, they got 220 pharmacists wrote in what they faced is their ethical dilemmas, and they actually shared their stories that way. Of them, they got down to 187 were eligible, some were excluded, down to 128. So that's a lot of narratives, things that bothered people enough to take the time to fill out a survey and write back in and tell a story, right? A story, a narrative, to share their stories of what was really bothering them and some of the dilemmas that they faced. They defined a moral dilemma as a situation in which there is a choice between at least two courses of action, neither of which is obviously morally preferable, right? So a true dilemma, what ought I to do? So that's the ethics of it. They broke them down into 3 different areas, 3 categories. The first category were those dilemmas between the pharmacist and the patient. So just that relationship between the pharmacist dispensing medications and the patient who is asking for it. No big surprise that drug abuse or addiction was listed the top, right? We've had some other talks about that. So that really wasn't surprising. Deviating treatment preference, I guess that would be not taking drugs as they're prescribed. So something's prescribed every day, but it's an expensive medication. So in order to extend their prescription, they might take it every other day, right? It's an autonomous choice, but it's not really being therapeutic in what they're supposed to do. Medication understanding, patient's privacy, sharing relevant patient data with other healthcare professionals. And here we get into a little bit, and I'm surprised that it's on the bottom, but it does have a fair number. Public health policy and third-party payer regulations. I think that's where the insurance comes in again, right? We can't always get what our patients need. The second category was pharmacist-colleague relationships. At the top, we have disruptive behavior of physicians. I know. They're not here today. Can't talk bad about them. Disruptive behaviors of other colleagues. Pharmacist and physician have a different opinion about appropriate pharmacopsychotherapy. Troubled relationship with the physician, deviating from prescriptions with the physician absent, right? What do you do when you have questions and you're trying to make a decision and you can't get back to who you need to? Missing data, loyalty conflicts, and physician self-prescribing, right? That would be an ethical issue. Again, I think these are such interesting topics that we could probably have a session and talk about each of these things for over an hour. And we can't, so I'm just giving you the overview. And the third category was various other relationships or involved parties. So here again, we have the issue of reimbursement. And then a lot of things about harm, right? Risk of harm to children, to unborn children, end-of-life pharmaceutical care, and dispensing without a prescription, and then quality defects, which that's an ethical issue. Again, I would love to spend an hour just talking about those issues. So you can see that there are a large number of issues that come up that can really deserve some good ethical response and some pondering and thinking about that. I decided that we would look at it today from a different perspective. I have Karen Okori, who's going to talk to us about outpatient pharmacy and the issues that we face here at Henry Ford, some of the outpatient pharmacy ethical concerns. We have Mike Peters, who does inpatient pharmacy. I always see him hanging around the ICU, which is where I hang out, so that's why he got dragged into this. But I think he'll give us a good perspective on that. And then on the phone, I have a provider. Dr. Jessica Shearing is an oncologist. She's practicing at Wyandotte. She's also the chair of the ethics committee there. So she is an excellent person to kind of wear both hats in talking about the ethical issues regarding drugs and obtaining drugs for her patient population from a provider view. So with that, I will turn it over to Karen.
So hi everyone, thank you for coming today to this session. As outpatient pharmacists, we deal with those moral dilemmas that Karen talked about on a daily basis during our practice. And sometimes the environment that we practice in, the retail setting, unfortunately influence some of our decision making and action. As pharmacists, our duty is to to work with every patient to teach them on the proper use and understanding of their medication so that they can optimize the care that they need. But we still struggle because we try to be there for every patient, but if you've been in a pharmacy, there's the whole setting. The phones are ringing. There's patients who are at pickup, patients dropping off, pharmacists being, asked to attend to different tasks at the same time, and sometimes it really hinders us from spending that one-on-one with the patient the way we want. So we try to ask the patient if they have any question, but are we really asking the proper questions to investigate if they are struggling and they don't know about it. If there's a way that we can increase their quality of life or when taking this medication, or put their mind at ease if they started an herbal supplement and they don't know that it could cause a drug-drug interaction with the current regimen they're on. And then even if you get the opportunity that a patient would like to talk to a pharmacist, and then you spend the time and then you discuss what you need to discuss with them, do we really ask them, to repeat to us to whether they fully understood? And we understand patients have different capability of understanding, so sometimes people, we have some patients that would require a little bit more extensive session than others, but at some point, where do you draw the line of, okay, I've got a line, I have patients getting upset because I'm taking too much time with this one patient, the phones are ringing, I need to verify prescriptions in the back because I don't want to delay treatment for other patients, and then you tell the patient to call you if they have any question. And we know when we try to let the patient, we try to engage them, but sometimes they either don't want to call, they're embarrassed to call and ask, they just try and deal with it and self-treat sometimes, which sometimes cause to more problems than solutions. And then if a caregiver comes in to pick up a prescription, sometimes the patient is not there, and if there's something that we need to communicate to the patient, at the point of sale, we don't know if it's the caregiver of the patient or if it's just a friend who happened to be stopping by and then, running an errand to another friend or colleague. How much can we go in depth, without breaching the HIPAA laws? Do we try and reach out to the patient? If we have a concern and the patient doesn't answer, do we hold or do we release the prescription in hopes that they will reach us back? Narcotics is a big topic here because we all are trying our best to minimize, and help with the opioid crisis that we all are facing. One of the biggest challenges, how do you know if this prescription that you just received is to treat a medical condition? We do have resources that we investigate, but then it would be up, unless you have a red flag that something is wrong and you can take it back to the patient or the physician and kind of have a discussion to why you're unable to fill the prescription, you're standing at a point where, okay, my gut feeling says it's not being used for medical use, and then I don't have anything on the other end to argue. So where do our professional judgment is then like put at a test, because you got to be very careful between your professional judgment and then profiling. We don't want to deny a patient their medication if they really need it. One of the challenges for us is that most of our competitors stopped carrying narcotics the way they used to because they don't want that liability. So now we have a lot of more patients coming in at hospital pharmacies to try and see if they can fill the prescription, which puts a little bit more pressure on us. We want to help, but sometimes we don't have the resources. And then if the patient is yelling and screaming and making a scene, some of our colleagues will fill it, and they'll tell them it's a one-time fill, even though they're not convinced that they can fill it, but they will do it. So we just have to look at the situation, and then we always try and tell the team that if a patient lives downriver, presents to your pharmacy here in Detroit with a prescription from a physician from Southfield, initially you'll be like, well, why is that patient traveling pretty much all over to get this prescription? So, you always kind of have that, oh yeah, something's wrong with this prescription. But then when you talk to the patient, you'll realize that they do live downriver. They had a surgery that they can't stay by themselves. They're living with their family member in Southfield. And then that family member works in Detroit. And because they can't find the medication anywhere, they're at our pharmacy. So we try to kind of always keep in mind, listen to your patients and don't have that assumption that something's wrong with the prescription unless you have some proof to it. Another big challenge for us is the cost of the medication. We have a lot of patients who come in. Once they realize how much the medication is, they won't pick it up. And if we know that they need it, it's something that they have to have, it's an urgent medication, do we release it or do we hold it? For our discharge patients, part of the discharge process is that we offer to bill them for their medication. So we won't hold the medication pending payment. We'll deliver it, and then we'll bill them, and then they can pay. They can pay the whole amount. They can finance. They can pay $5 a month. As long as they're, keeping that account alive, we're good with that. But on an ambulatory site, I can't do that. It's a retail setting. It's a business. And we cannot pretty much give free medication for every patient that, cannot afford it. So, and sometimes we do exceptions. Sometimes we pay for the medication. Sometimes we reach out to social work and engage them. And sometimes we just have to give the medication and work on a plan to be able to justify further fills. And then how can we support those high copays? We try from our end to look at vouchers, copay cards. Some medication have them, some medication don't have them. Vouchers are very cool. Patient pays out of pocket $0. But then what's the plan for day 31? Did I just start a patient on a medication that I cannot have them continue on? And then lapse of therapy, patients will, health will deteriorate, and then they get back to us either through the ED or, through a direct admit. And then sometimes we look at some of the prescriptions that we receive with a high copay. We try and do our due diligence to research the patient history and see if this is exactly the only choice, or if there's any alternative that are cheaper that can achieve the same goal as this medication. Because I know some of the physicians get detailed by the manufacturing companies, and then they talk about and discuss those new branded medication on the market, and it's like it's going to save the world, and the physician writes it. But then the patient is suffering because that's an additional copay burden that they have to deal with on a monthly basis. But what if it was the reverse? What if it was truly the only choice? And am I kind of depriving a patient from an optimal therapy to a suboptimal therapy? And some patients will pick up a medication, they'll go home, they'll think about it. Well, I cannot afford this inhaler for $40 a month. They'll come back and they want to return it. Our state law does not allow us to take any medication once it leaves the pharmacy. At some point, the patient is in front of you, they're crying, this could go to their, rent, to their bill, and then, what do? Sometimes you have to just take the loss and take it and just dispose of it, give them their money back. But again, consistency, can we do it every time to every patient? And then who decides who gets it and who doesn't get it? Is it situational based? Is it based on the professional judgment of the pharmacist? So these are the things that face us every day. And then, patients who come in, they're visiting out of town, or they're just haven't seen their physician, and they ran out of medication, they don't have a prescription. And they're in your pharmacy on either a Friday night or a Saturday or a Sunday, and they want their meds. Sometimes it's not even filled at your pharmacy. You don't have a history of their, medical, you don't have a medical history, you don't have a history of their prescription. You don't know if this is actually the most current medication that they need. Okay, so, what do? Some of us will give a few days until Monday, until they have another plan. But then we do it for pretty much tablets, non-controlled medication. What if it's an inhaler and insulin? And then what if it's a controlled substance, but it's not pain medication? It's used to treat epilepsy. You know what I mean? So again, it all falls back on the professional judgment of the pharmacist. So it depends on who's working and how much they're willing to make that decision. Then, that dictate the, the end result. So this is one, actually it happened to us here where we had a patient, 54-year-old female. She has a history of chronic back pain. She comes to the pharmacy every month with a prescription of hydromorphone. She's been on it. We know her. She's a regular patient. She never asked for it to be refilled early. She understands that we need to run, MAPS, which is the Michigan Automated Prescription System, to make sure if there's any fills of controlled substance outside of that prescription. Everything checks out. She's very friendly. We know her by first name. Then it turns out that her urine test came back negative for opioids. So whatever we've been filling, she's not taking herself. We contacted, we got concerned, okay, so we contacted the physician. The physician would not cancel the prescription, given everything that we stated. The recommendation was to give her back the prescription so she can go fill it at another pharmacy. So this is just part of what we deal with on a daily basis. I have examples, but due to the time, I'm going to have to turn it over to Mike here. Thank you.
You're not going to tell us what you did?
Oh, we gave it back. But we did put a note that we told the patient that we can't fill her prescriptions here anyway.
Karen, tell her we'll take questions at the end.
Okay. We'll take questions at the end.
So how do you got this going? Oh. Hi, I'm Mike Peters. I've worked at this campus for the past 31 years in the medical ICU, but I also feel Karen's pain. I worked in retail pharmacies also for my entire career. I'm currently at a small mom and pop pharmacy where I've been there for 15 years. I just work on Saturdays, which is one of the bad days to work because you can't get a hold of anybody to help you. But I just wanted to go back to the beginning. Every single one of those things that somebody wrote a dissertation on, I've experienced. I've experienced all the things that Karen has experienced. But to be honest with you, I've only experienced those things in the community-based pharmacy. So for pharmacists in the inpatient setting, like I work in the medical ICU, I think we're sheltered a lot from some of the ethical things that they have to deal with on a regular basis. So I got the easy part of this ethics discussion today, although we have issues. So Karen had asked some questions of me, and I just actually tried to answer her questions because, honestly, from an ethics standpoint, I know where you're coming from, but it's a lot harder from her end. So who decides who gets an expensive drug or actually any drug that goes to a patient? And the pharmacists, even in retail pharmacy, but here, pharmacy doesn't decide, for instance, who gets any medication here, from the writing of a prescription for an individual patient to actually what's on the formulary here. So how do we interact with the drugs that are on formulary, and what do? We do all the research for any drug that would be available on the market. We write a very extensive report. We look at all the literature, the outcomes. We actually know the costs of the medications, but they sit in a pile until somebody on staff here requests that medication or asks that medication to be possibly added to the formulary. So unlike a drugstore, in a drugstore they have every medication or could have every medication available in our country. They don't, but they could. Here, by conscious decision from a system standpoint, we don't. We have medications that we think we need to provide to our patients, but we don't have all the medications. So if a medication is a class of medications, things for blood pressure, let's just pretend it's called a beta blocker. There might be 15 or 20 of them on the market. We might have 5 of them here, and it's by decision and by choice. So what we do is, if someone petitions that they would like a medication, we then review in a committee format everything that we've put together, the file on the medication, and then the medical group here votes on whether we add that medication to formulary or not. The pharmacists don't vote. So if something's extremely expensive, it's kind of considered. If something's really cheap, it's considered. But it's not the pharmacist who actually make the decision. Where we come into play later on is if there are medications that sort of the outcomes are similar, we might sort of educate, or we do educate, especially the residents, like if you can do something cheaper and there's the same outcome, we prefer that you do that. When we advise them on rounds and we talk with them, but if they choose to use the more expensive medication, they do. We don't argue, we don't fight with them, for instance. We don't deny that. But on the back end, then Karen gets a prescription for that. Their insurance may not cover it out of hospital, and then they have to do something different anyway. So we try to circumvent those kinds of problems, and we do make sometimes restrictions or extended reasons why you might choose a more expensive medication over another. And we work very closely with each department. So if a drug is mainly used by the gastroenterologist, we'll work with them and say, you know, if you can do these cheaper medications first and then they fail, then it's okay to go to a more expensive medication, because ultimately their insurance might not pay for it anyway. But then we find that, you know, physicians still like to choose those more expensive medications, and then you have your problems that you can't get a medication. So essentially, a majority rules in those situations. They get either denied formulary access or they get on formulary, and cost versus outcomes are considered. We have, our system has denied medication use for inpatient based on cost if we feel that it's not going to impact what happens in the pharmacy. So for instance, there's a new medication that works for preventing a patient from getting infectious diarrhea. So it's something that happens if you're in the hospital, but if you already have it, it doesn't benefit you to get it while you're in the hospital. It only benefits you to get it when you leave, and then you might not get it again. So for instance, we've denied that from formulary because we don't think patients in hospital, but if someone prescribed it and they came to your pharmacy and needed it, probably unlikely, but you would have to get it and see if their insurance pays for it, and then because it's very, very expensive, and then you'd have to work through those issues. So some of these things I feel I don't have to deal with. So my job's a little bit different. There's some new things on the market, and Dr. Schering could probably comment on these better than I can, but there's a new chemo-type drug. It's the first drug. It's for non-Hodgkin's lymphoma who fail other kinds of treatments, called Discarda. It's extremely expensive. Like talking between, I'm going to sort of make up a price because I'm not 100% sure, but like $750,000, let's say, to do this therapy. And so what's happening now is many institutions are at a crossroads, and they're deciding, like, how are we going to give this or treat patients with this therapy? I won't call it a medication. It's kind of a medication. Because it's so expensive, what they're doing is they're having their oncologists meet, their tumor boards, whoever they're meeting, and then with the insurance company before the patients are prescribed these things, they meet with the insurance company and they decide if the insurance is going to pay for this or not. If they pay for it, they get the therapy. If they don't, they get denied. But again, this is not really a pharmacist decision, but it's how we're working now, which may happen more and more in the future, where these drugs are ridiculously expensive, where we can't afford just to give everybody who comes in this situation. If we don't get reimbursed, again, we're still a business. We go out of business. So this is something new and different, not experienced this. Generally, when you're in the hospital, if something's expensive, it's covered under your DRG. It's whatever the hospital's going to pay, or whatever the insurance is going to pay, the hospital usually accepts. End of story. We don't usually talk about these things on rounds, for instance. But this is innovative and different, and it's probably going to happen more and more where situations arise like this. There really is. So for non-formulary medications, this is a little bit of a different scenario for us in the hospital. Something's not on the formulary. We either decided we weren't going to carry it, or we never reviewed it for the formulary. What happens is we have a formulary committee. It's run by a physician. There's a chief, and there's multiple physicians, and there are pharmacists on this committee. When somebody prescribes a medication that's not on our formulary, they have to call a member of this committee, and then this is the one time where a member of the committee will decide at that moment whether we can prescribe this medication or not. So in this scenario, this is the one time there could be a pharmacist who's deciding whether or not, depends who's on call essentially. Usually the head of the committee is the person everybody calls, but sometimes they're not available. So these medications could be not expensive, they could be extremely expensive, but that's the one time where one person will make a decision as to if this specific patient can get this medication or not while they're in the hospital. This is pretty unusual. We have medications for most scenarios. I can think of one. There's a medication for ALS. There's only one medication that's to treat ALS, Lou Gehrig's disease. It's not on formulary, so if someone comes in from home and they're on it, you can't say no. There's only one medication for that. Oftentimes, we circumvent the problem by asking the patient to bring their own medications in. So we still have workarounds, but this would be the one scenario where one person would decide whether or not a medication would be given to somebody. Again, if there's no insurance, it's whatever the hospital's doing as far as getting payment is what happens to the pharmacy department or medications. If we're not getting paid for an admission for whatever reason, we don't worry about the drugs. It's part of what we do. We eat the cost sometimes. We don't send them a separate. I mean, we might bill them, but if we don't get paid, we're not getting paid. We don't treat it any differently. We don't pick and choose the medications based on if you have insurance or not. We treat you, if you're an indigent patient, we just treat you. So that's different than, Karen, they can't do that in a retail pharmacy. I work for a mom and pop pharmacy. You can't just give people medications. Here, we kind of do. It's part of what we do. So again, I'm absolved of those kinds of things. I feel guilty.
Both feel guilty.
So yeah, we don't use coupons or things like that. It's just part of what we do. A person, like if you see, what if the patient agrees to pay privately for a super expensive drug? That's again not really going to happen. That's between finance and the hospital. We don't have to deal with that. MD coercion to get drugs for their patients. Again, we don't deal with that. They can call, for instance, if it's non-formulary, they can get a med like that. Otherwise, there's no way to get meds that aren't on formulary. So we don't really have to deal with that. And then diversion. So diversion is a real problem. We have had many people in the past 30 years get released because of diversion. We've had people arrested. We actually have a monitoring system electronically that alerts us to suspicious activities from either providers who have access to narcotics or controlled substances, or nurses or pharmacists. I will tell you, the person who invented our monitoring system got caught, is no longer with us.
Wow.
So they were their own.
Interesting.
That's interesting, right? So, yeah. So it's real. It happens. We try our best to monitor those things, but yeah. So again, yeah, we could probably talk for hours about lots of those things, but.
Okay, so Dr. Jessica Shearing is on the phone. Jessica, are you there?
Yep. Can everybody hear me? That sounds okay?
Yep, you're good. You're good to go.
Okay. Hi, everyone. I'm sorry I couldn't be there in person. I'm a one-person show down here at Wyandotte today, but I'm really excited to talk about a couple of these topics, and it's a big issue for us physicians as well. So I'm a medical oncologist, as Karen was saying, here at Wyandotte, and also being part of the ethics committee here. I mean, it's very troublesome, some of the issues that we have to deal with. My first slide, what I was wanting to talk about was how we're influenced, perhaps by whether it's a brand name drug or generic. A lot of our patients are concerned that perhaps if we're giving them generic, even sometimes if we're helping fill a prescription for like blood pressure medications, cholesterol, of course we have, Lipitor, but then there's atorvastatin, which is the generic. But a lot of patients actually are feeling that they're getting gypped because they feel like the generic is weaker. And to be honest, the generic drugs are actually cheaper because the makers of these drugs don't have to cover the cost of development and marketing of a brand new product. And the generic drugs are actually, they're required to show a bioequivalence, meaning equal efficacy as the brand name drug. So it's really a matter of educating the patients, too, just to give them that peace of mind that the drug that we're prescribing, of course, as providers, we want to be sure that we're giving them the drugs that they need and that work just as well. That second bullet that I put there's a concern for any kickbacks towards physicians. This is I'm hoping slowly fading out. But, over the past decades, I mean, there had been not just financial kickbacks, but trips and different aspects that pharmaceutical companies would give back to physicians in order to boost their sales. There was some data that I think it was 2014 where the government unveiled that there was about $4.5 million of payments made to doctors and teaching hospitals by these, like, either medical device companies or pharmaceuticals. And that gives a lot of concern. A personal example of mine is I had to go to a dermatologist to deal with an issue on the skin. And they were trying to, and I feel like as a physician, they didn't know what I did for a living. But I saw the look that they gave each other about wanting to prescribe the particular cream for me. And they were like, you know what, you'd be a great candidate for this new drug that we just got. And they looked at each other like, I wasn't sure if there was a kickback involved, but it just seemed a little suspicious. And sure enough, that drug was between $200 and $300. And so I was a little off put because, to be honest, I felt like there were probably some other things that could be done. But it's still an issue, I think, that's out there today. And even for myself, we prescribe things like chemotherapies. And as Mike was saying, these newer therapies that are just so incredibly expensive, there is that concern from patients that there's some skepticism, and so we really need to be mindful of that and be very transparent, really, in talking about the costs and making sure that they're connected to good financial and social workers in those situations. And as Karen said, it's a matter of justice. The whole thing is we're trying to make sure that patients are getting the drugs that they need and that they deserve. The next slide that I had a bullet point of what if your patient's insurance company won't approve a beneficial drug. So a quick example is I have a lung cancer patient, a lady in her 60s. She's stage 4. And now in stage 4, I mean, typically we would just start with chemotherapy, but nowadays when we're diagnosed with stage 4 lung cancer, a physician, by guidelines, we send off for special testing to see if they could qualify for an oral chemotherapy pill or maybe immunotherapy, which is medications that more enhance your immune system. So they're much more tolerable medications. So sure enough, we did the testing on her and she qualified for everything. She was able to get the chemotherapy pill. She could do the immunotherapy. So because of her burden of disease, we started with chemo to rein it in. And now we're getting to the point where, she's getting a little sick of it. She wants to move on to something more tolerable. And so we're like, let's go ahead and do the pill. Well, we run it through the insurance company. Copay is $4,500 out of pocket every month. Why in the world would I send that test if I knew that was the outcome? I mean, everyone's insurance is a little bit different, but this is some of the frustrations that we have as physicians, that we have these great drugs for you, but, you can't have them because you can't afford them. And of course, we do have programs that can help, but with that kind of copay, there's only so much resources that we have. So that's where that becomes an issue. I'm going to talk in the next slide really quick about an initiative that's been going on with the state of Michigan to try and help with these costs, but we'll get to that. The next bullet is talking about off-label use of medications, whether for trials for patients that we think could benefit. So this is kind of interesting because while we run into issues of obviously off-label use, that means basically that the drugs aren't studied in the way that you're attempting to use them. So while you can make appeals, they're not usually overturned. I had I keep giving case examples, but one other example, a sweet 85-year-old, great shape. I feel like he was like the Hulk of an 85-year-old. Like he was so super strong and in great shape for treatment. But he had a very aggressive lung cancer. It was not bothering him. It was very surprisingly slow moving, which was atypical for that kind of lung cancer. But he didn't want chemotherapy. And for different types of cancer, if patients wouldn't want chemotherapy or we feel they wouldn't be able to tolerate it, we can scrap first line and say, let's move on to the next. And next line for him would have been immunotherapy. Again, drugs that enhance your immune system instead of kind of hammering you down with the chemo. So I put in for that order for the patient, and they denied it. They said, no, you have got to give this 85-year-old aggressive chemotherapy before we will approve immunotherapy. Well, I was a little upset, and so I was putting in for more appeals. And then they noticed in my note that I commented about his kidney function was a little bit off. And they hinted to me, and this was more our authorization team and insurance, if you were to expand on that and kind of hinting at me that talked that his kidneys weren't working well, then we will approve it. So this also, and I put in the last bullet point, addending the notes and changing things to kind of fit the perfect, puzzle piece that insurance companies will approve is a little bit of an ethical issue on the physician's part. I'll tell you, for this instance, I had no problem doing it because I was concerned for his kidneys and I didn't want to give him chemo. So in that case, it ended up working. But there are many issues where we're trying these trials of drugs, whether it's for blood thinners. I'm also a hematologist, so these newer agents you see, Eliquis, Xarelto on TV for blood clots, they're not readily approved by insurance. They want you to try Coumadin or warfarin, kind of our tried and true blood thinner there. So that comes into issue where they won't approve it. Also issues for nausea medications. We try and help stimulate people's appetite with medications. And more often than not, they do get approved, but we run into issues sometimes where we do get denied, and we have to tweak our notes a bit to make it fit. So those are just some of the issues that we deal with. I know we're cutting it a little close for questions, so I'll try and speed it up a little. But that next slide, talking about oral chemotherapy, it's really, Michigan is 1 out of 7 states without law requiring insurance companies to cover the cost of these medications. Physicians, a lot of medical staff, including organizations such as the American Cancer Society, is currently advocating that in the state of Michigan. But it's been rejected for nearly a decade because, roads and other things, I guess, apparently are more important. But this is becoming an issue, just like the patient I mentioned before who had a $4,500 copay. Like, she may never see that good drug, and I've lost a tool in my tool bag that I can treat her with. So an issue, too, is we have new representatives that need recurrent education of this issue, and we really need to be helping these organizations advocate for that and keeping it in the ear of our leaders. So that last point I have in my last slide was when we refer patients to phase 1 clinical trials. So phase 1 clinical trials there's 3 phases. Phase 1 is not meant to really give a benefit to the patient. It's really, for lack of a better word, the guinea pig trial to make sure people can tolerate it. How high can you push the dose before they start having side effects? But some of these phase 1 trials lead to drugs that are great drugs. So it's a chance for when patients don't have any other options to give it a try. And so that's typically when I refer patients to phase 1 clinical trials. But there is no standard pathway of how you have to do this, but some physicians also ideally bring this up in the beginning of meeting a patient. But there are some physicians and maybe some questions where, we wonder, being a primary investigator, a lot of physicians are, part of their job is to work in clinical trials, and part of that is to get grants and to get funding, and part of that funding is, part of what helps them in their salary. So there are some, and I'm not saying at Henry Ford by any means, but I'm sure out there are some that are really pushing clinical trials a little bit too early in patient care, just to make sure that, we're keeping the numbers up. But traditionally, it is meant, as it says there, when there's nothing left, we try for beneficence or to help the patient. Versus, the question we have of the study knowledge, we're risking harming the patient with the toxicity and side effects. But the way I put it to my patients is we're constantly weighing, the risks and benefits of, controlling the tumor, controlling the disease, but maintaining you and your quality of life. And I think ultimately as a provider, that's my ethical balance. Especially when I'm dealing with drugs and chemotherapy all day long, is I'm always trying to find that balance. And sometimes I'm finding that balance by not doing quite the standard dosing and reducing things as long as I'm controlling disease. But that's just something I struggle with a little bit every day. But I think every day I'm getting a little bit better with it. So I'm sorry, I know we're cutting short on time, but.
No, I think that was absolutely perfect. So we have about 5 minutes left for some of your questions. We have such great, I've learned a lot. I always learn a lot. I think this brought up a lot of issues and was really a timely discussion. And I have nothing but respect for the difficult moral job that our pharmacists have to deal with every day, right? All right. Pastor Deborah, you have a question. So the question is, who makes the decision between brand name and generic prescription orders?
Well, just from my standpoint first, I was going to say, because Jessica mentioned that in the hospital, if it's available as generic, you get generic. There's no choice in the hospital. But usually your insurance company decides your copay, so I'll let you.
It starts with the physician and the way they write the order, but in your case, you did get a prescription for the generic. It's unfortunately the insurance company that classifies the tiers and the copays, and the drug companies that set the price.
So just go ahead. But just to let you know, I mean, their job is to try to take this pool of money that they're supposed to disperse to everybody. I know you paid into it. You feel like you deserve, justice. But they try to, everybody's got to live off of that money. So they try to, have tiers and have copays so they can spread the money to everybody who gets that insurance. It's part of the problem.
There's another question. Can you repeat that
Yes.
question too?
Comment about prescriptions when they're written. Like if the doctor puts DAW on there, that means dispenses written. So whatever that medication is, that's what they have to fill. Was the dispenses written?
Yeah.
And so it may be a generic for, usually it's a trade name that they want the patient to have because that works better. So they write dispenses written. I mean, they want them to have that as opposed to the generic.
Yeah, so dispenses written is something that can be done by the physician if they want you to have only the name brand. There are probably a few medications where it's really, really important to have dispenses written, but for the most part, generics are fine.
I'm thinking my thought had always make you do the generic. What if they do ask for dispenses written? Will the insurance company pay for that, or are they going to make you buy clear?
Can you repeat the question
The-
for people streaming?
Sure. The question is if the
If they write
prescription is written with a DAW, Do we still have an issue with trying to fill it at a reasonable copay?
Yeah.
It varies per plan, and normally if there's a generic available and the physician writes a DAW that dispense as written, sometimes we will need to do a prior authorization to get an override explaining why you would need the brand and not the generic that's available. And then even if we get it approved, it will be considered a different tier, which is a little bit more expensive. So the cost is being shifted to the patient, for utilizing the brand when in the mind of the insurance there's a generic equivalent that should be utilized for the same medical outcome.
In the state of Michigan, the pharmacist is actually held responsible for the quality of the drug they purchase to dispense to the patients. So generics are rated. They're rated, AB rated is the highest rating, AB. So if we don't buy an AB rated drug and your outcomes are not good, we can be held responsible for that. So we typically only buy the highest rated generic equivalents.
That's available,
Yeah.
correct? Yes.
I had mentioned that in Michigan, maybe coming up with a plan to help people with their expensive medications, but really high copays. I don't know if you got back to that.
So a plan.
Yeah. This question is for Jessica. I think, is there a plan for the work that you're doing with the state in order to minimize the out-of-pocket coverage for patients? With the high
Yes.
copay?
Yes. So some of my colleagues have been down to the state. Basically, what they're doing is they spend I'd say quarterly, they try and spend a day down at the Capitol to really just be out there giving education, trying to catch, our leaders, representatives, senators, just so they can understand the issue at hand. I actually haven't gotten to be a part of a personal hearing yet, but it's almost something to where, as